Hi, my name is Chad Hales, Clinical Director of Emory Cognitive Neurology, and Associate Professor of Neurology in the Emory University School of Medicine. I wanted to provide a brief update about amyloid monoclonal antibodies as a treatment for mild Alzheimer's disease. The purpose for this webinar is to share a few comments about Alzheimer's disease in general, talk a little bit about how amyloid monoclonal antibodies work, how they're administered, discuss a little bit about how medications may help with memory symptoms, go over who should be treated with donanemab and lecanemab, which are the two medications, briefly discuss side effects, a little about cost, talk about duration of therapy, and then have a few summary comments. So a couple of things to start out with. We know that Alzheimer's disease is a devastating illness for patients and families. We know that we also want treatment for this disease because of the effects that it has on cognition, as well as interpersonal relationships and overall life and quality of life as you move forward in time. It's important to place what expected outcomes might be in context with data from the clinical trials, as with any medication, and recognize that with donanemab and lecanemab that we're balancing possible benefit with a real risk of harm while trying to follow the FDA label guidelines. It's important that everyone to be informed of what we know about these medications and also what we don't know. So how do they work? Donanemab and lecanemab are humanized immunoglobulin monoclonal antibodies that are directed against amyloid beta. So antibodies, as you know, are used to fight infection in your body. And in this particular case, a form of antibody was created to bind amyloid beta or beta amyloid, which is a fragment that accumulates in the brains of people who have Alzheimer's disease. And we know that these plaques are a defining pathophysiological feature of Alzheimer's disease. So the goal of this therapy, once you have a degenerative process, here I'm showing you some hippocampal atrophy, I'm showing you some plaques that are here. The goal is to try to remove those plaques from the brain in hopes that it might alter the clinical trajectory moving forward. These antibodies, you might say, well, where are they made? They're actually made in large vats by cells, and these cells are called CHO cells, or Chinese hamster ovary cells. So they're made in a dish and then put into vials and then transported for preparation and intravenous administration. So how are they administered? Through a peripheral IV. The frequency for lecanemab is every 2 weeks. For donanemab is every 4 weeks. This requires going to an infusion center where an infusion nurse will place an IV, and you'll sit in the chair for a couple hours and have the infusion completed. The duration of the infusion time varies. For the first couple, you may be there for a little extra time, just for some extra observation. But once infusions are going well, you could be there for as short a period of time as an hour or two at most. One of the questions that comes up is, do the medications actually help with memory symptoms? I'll start by introducing a scale that was used in the clinical trials to try to determine if these medications were helpful. In this case, it's something called the CDR, or Clinical Dementia Rating Scale, sum of boxes. And it's a questionnaire that tests memory and orientation, all these other items that you see here. This is an 18-point scale where 0 is normal and 18 is severely impaired in cognition and function. So how was this used in the clinical trial? I'll show you data from both lecanemab and donanemab. These are both in the FDA label. For lecanemab, and well, both really, people who were on medication, so the upper line in both, declined at a slower rate than those who were on placebo. You can see that down here at the bottom of the graph, the number of people who were in the trial on placebo and on drug, similar down here, placebo and on drug, for 18 months. And on the y-axis, these are numbers from this CDR. And you can see the scale here goes from 0 to 1.5 and from here from 0 to 2.5. And so this is on an 18-point scale. And I've just arbitrarily designated a few points on this ramp here. And so the point being, there was a statistical difference in people who were on drug than those on placebo. The question becomes is what type of meaningful difference does this provide for individual patients? The answer to that may not be entirely clear, but some people want to know, does it help me work around the house better? Doing household chores, managing finances, or helping to cook or clean? Does it help with your memory by somehow bringing memory back if you have some memory loss? If you're having navigational difficulties, does it potentially help with improving some of those? Keeping track of bills or other important things in your life, or even names. Does it perhaps help with names? And the answer is, well, we're not entirely sure which of these things that this may help with. But when you look back at the data, we know that these medications seem to slow their trajectory, but they may ultimately not make symptoms that are present get better. And so that's an important point as you move forward in time. If these medications are started, the expectation should not be that it stabilizes or makes things better. The goal is that best case scenario would slow the trajectory to such a slow rate that the perception of decline is very, very slow as compared to what it would have normally been had you not been on one of these medications. So who should be treated with lecanemab and donanemab? From the label, they're both indicated for the treatment of Alzheimer's disease, and treatment should be initiated in patients with mild cognitive impairment or mild dementia stage of disease, the population in which treatment was initiated in the clinical trials. And so what we've tried to do is as closely as possible to follow the inclusion and exclusion criteria within those clinical trials. There are some caveats to that, in that some stipulations in clinical trials are there to really create a homogeneous population, whereas using more so in the community, there may be some variation in what's acceptable as an exception to going on one of these medications. Of course, any decision-making based on inclusion and exclusion criteria will be in the context of risk-benefit discussions, and does it potentially increase the risk of harm? But in general, you can see the age groups here. I've already mentioned mild cognitive impairment or mild dementia with biomarker-confirmed Alzheimer's disease, and that's either with spinal fluid testing or amyloid PET. There are blood-based biomarkers which are being used for Alzheimer's disease as a screening tool. They're not currently fully recognized yet as being confirmatory for Alzheimer's disease, and it's possible that as we move into the future, that may change. But for now, confirmation of Alzheimer's disease needs spinal fluid testing or amyloid PET. Symptoms need to be quite mild, and in general need to be independent in basic activities of daily living and just very minor impairments in other daily activities. Other things, including MRI brain and lab studies, need to be without exclusions. So who should not be treated with lecanemab? If you're not able to have an MRI of your brain, then these medications would not be an option because MRI scans are needed to monitor for side effects. And if you can't have an MRI, these medications would not be a right choice for you because we couldn't be able to manage you safely. If there are certain baseline criteria on the MRI brain that show prior bleeding or other causes of cognitive symptoms, this could also impact eligibility, but would need to be placed in context with the overall setting and discussed with your provider. Unstable severe psychiatric illness or vascular risk factors are also a problem. And importantly, elevated blood pressure or hypertension that's not well controlled has been identified as a possible risk factor for some of the side effects that can occur on these medications. And so maintaining optimal blood pressure control is likely helpful in reducing risk for side effects. Having a history of a bleeding disorder can also be an issue, just because these medications can have an increased risk of microhemorrhages or bleeding in the brain. There's active treatment for cancer that could also be an exclusion, but again, there are some minor caveats to that if there's a type of maintenance therapy, but cancer is relatively well controlled. Immunological diseases requiring immunosuppression are also something that has to be discussed as whether it should impact the ability to go on these medications, partly from a standpoint of if your immune system is not working properly because of the immunosuppression, it may actually make the medications not work as well because it requires your host immune system to function properly. And probably one of the most important is patients who are too impaired should not be treated with these medications. And we know for many years, over the last 2 decades, really, of the different trials in Alzheimer's disease, that treating patients with this approach of removing amyloid from the brain, particularly if patients are further along in the process, that this approach just does not seem to help those patients. And so in general, it is not advised. So what are some of the side effects? I'll show you a couple of lists here of lecanemab and donanemab. These are again from the FDA label. A couple to point out. Infusion-related reactions are one, and you can see here for both of the medications. These can be acute reactions that occur when the infusion is started, or can occur in the hours or a couple of days after the infusions. It can be as simple as some flu or fever-like symptoms, all the way up to a robust hypersensitivity reaction that can be quite dangerous or life-threatening. You can see the percentages here for lecanemab were around a quarter or 25%. Not as high for donanemab. Unclear the reason for the differential. Headache is also on the list for both. You see rash here with lecanemab, but probably the one that people get most concerned about is ARIA that you see here. ARIA stands for amyloid-related imaging abnormality. The H stands for hemosiderin, sometimes hemorrhage, and the E stands for edema or swelling. And you can see that in general, the percentages of these are not low. And I'll have a chart to show you in a moment of that breaks this down for you further. In that context of ARIA, most of the time it's asymptomatic, but both of these medications have black box warnings by the FDA, and they can rarely cause serious or life-threatening events, which I'll share one of those for you in a moment as well. There's also an increased risk for people who carry copies of E4. So apolipoprotein E, it's a gene or protein that everybody has. And if you have specific copies of the E4 allele, then that can increase your risk for having these side effects, which is why, as part of the workup, testing for ApoE genotype is conducted so that the appropriate risk assessment can be discussed with you. Showing an example here, this is an MRI of the brain with the back of the head down at the bottom of the screen, front of the face up at the top of the screen. Here you can see a pre and a post, and you can see this little bit of white signal change here, which represents swelling. This is a scan, another special sequence, which is showing a few microhemorrhages that have popped up, as well as a little bit of blood layering on the surface of the brain, also another side effect. So ARIA-E in the first sequence, and ARIA-H in the next sequence. And this is that chart that breaks down the percentages for you a little bit better. In general, most of this data comes from the phase 3 clinical trials, with one caveat, which I'll describe in a moment. I'm showing ARIA incidence over here, ARIA all types, ARIA-E, ARIA-H, and then stratified based on ApoE, so not having any copies of E4, one copy of E4, or two copies of E4. We'll start with this first line for all types of ARIA, and you can see that for donanemab, it was 36%, and for lecanemab, 21%. So showing a little bit of a discrepancy, a higher rate of ARIA on donanemab. And you can see similar elevations across some of the other numbers as well. You also see that as you increase the copy of E4 from no copies to 1 copy to 2 copies, that for both donanemab and lecanemab, the risk goes up, although apparently a little bit more on the donanemab side. The one caveat, though, is you'll see a little asterisk here by a couple of these numbers, and that's because some additional data was recently published for donanemab using an updated titration schedule. And I'll share a slide on that in just a moment, but basically the way that these medications are given is via infusion, and the company decided to adjust how the first few infusions of donanemab were given so that it was a little bit slower ramp in increasing the infusion dosing. And by using that slower titration, the percentages for ARIA seem to be a little bit better. And so you can see here dropping down to 29%, down to 16, down to 25. It's important to note that the overall data presented in this chart was from the 18-month clinical trial, whereas this data with the asterisks was in a 12-month trial. And so there are some nuances to this data, but it does suggest that the altered titration seems to lower the risk of ARIA for donanemab from the higher numbers. When looking at symptomatic ARIA, so those are amyloid-related imaging abnormalities that actually cause symptoms for people. If you look at ARIA, all types for donanemab, 6% versus 3% for lecanemab. Again, if you look at in that updated titration, it seemed to cut that risk in half. And although I mentioned ARIA all here, the majority of that is being accounted for by ARIA E. This is also stratified by ApoE status, and you can see here in the original data, increasing ApoE burden. So no copies, 1 copy, or 2 copies increases the risk of symptomatic. And the same for lecanemab. Again, there's some asterisks next to these numbers, and it's important to note that in that updated titration, the small number of events and unlimited exposure to the ApoE subgroups in the donanemab titration limit definitive conclusions about the risk on ARIA-E. So even though these numbers look a little bit better, the numbers in this trial were small. And so you do have to just take that into account when looking at the data and trying to compare it directly to these other numbers. You can see that serious events are listed here, and again, increase seemingly with 2 copies of E4. Just briefly to explain the titration for donanemab and what happened to perhaps lower that ARIA risk and maybe get it a little closer to lecanemab. Let me orient you to this chart. This is from the article here. Modified titration of donanemab reduces ARIA risk and maintains amyloid reduction. This is showing you 4 different arms that were tested in the clinical trial. Up here is showing you the study week, 0, 2, 4, 6, etc. And the standard dosing, this is what was originally used in the phase 3 clinical trial. So you can see at the start, a patient would receive 700 milligrams intravenous. At week 4, they would get another 700. At week 8, another 700. And then it would bump up at week 12 to 1,400 milligrams and stay at 1,400 milligrams thereafter. For the modified or updated titration, we'll actually ignore these other 2 for the time being, but for the modified titration, it actually shifts one of the doses. So 350 milligrams from this third dose, it shifts it from here over to here, right? So from the first dose over to the third dose. So now your first infusion is 350 milligrams instead of 700. 700 at the second or the 4 week, and then 1050 at the third dose, followed by 1,400 thereafter. Again, the concept being that the slower ramp up may help to reduce the risk of side effects. When thinking about how to gauge side effects on the brain scans, because safety MRIs are conducted throughout the first 6 to 7 months on both medications, there are charts within the FDA label that help advise providers on how they should treat the findings on the MRI brain. And remember, most of the findings are asymptomatic, and so we need a way to grade those on the scan to know how concerning they should be. And so typically there's a radiographic finding based on the amount of the change. Here I'm just showing ARIA-E, for instance, and it's graded mild, moderate, severe. And if you want to get into the weeds, it's there are some explanations for what these actually all mean. And then that's also coupled to the symptomatic severity. So is the patient asymptomatic, or do they have mild or moderate or severe symptoms? And you can see that for mild symptoms, that in general, if it's mild radiographically and the asymptomatic or mild symptoms, that you can even consider continuing through dosing. And in some or most cases, patients would have a bit of change on the brain scan, and then it would just resolve and heal as you move forward. In some cases, dosing may be suspended or even stopped permanently, depending on the severity. An important side effect to talk about is represented with this case. And in this case, a patient presented to the hospital for a cause not necessarily related to the lecanemab that they were on, or amyloid monoclonal antibody they were on. And they presented with stroke-like symptoms and got standard of care, including a thrombolytic or clot-busting medication, and unfortunately ended up having lots of different hemorrhages that formed and some swelling, and ultimately ended up dying after that event. And so there is this risk, particularly in the first few months of being on drug, that if you're one of the people that develops some of the ARIA, and it's not necessarily recognized as part of the underlying condition, or in some cases, it may be so small that even if you did some imaging, you might not recognize it. You could be at increased risk if you're given a strong blood thinner. And so this is something to keep in mind, that there are some rare instances where a strong thrombolytic or blood thinner, if given in the right set of circumstances, could lead to a very bad outcome. Of course, you're often kind of stuck between a rock and a hard place with these types of situations, because you may be having another situation that requires emergent intervention, such as a stroke or heart attack or something else that requires a strong blood thinner. But just recognizing that it could place you on a tough spot if you do end up presenting and needing a blood thinner. And also recognize that some hospital systems will have some restrictions in place on what types of blood thinners can be given in patients who are on lecanemab and donanemab. So which medication should be considered? The efficacy is likely similar between the two medicines based on the data from the phase 3 clinical trials, although we don't have a head-to-head trial comparing the two. The infusion frequency is a little different, and so that may weigh into decision and impacts to quality of life. Again, donanemab every 4 weeks, lecanemab every 2 weeks. The infusion reactions may be a little bit less with donanemab, but in general, most infusion reactions are manageable when they do occur, and are often treated with some over-the-counter medications before and after infusions, if you're one of those people who develops them. And typically those medications like cetirizine or Zyrtec or a little acetaminophen or ibuprofen prevent those reactions from occurring. And usually several infusions down the road, you can end up stopping those pre and post medications, and the symptoms do not recur. It's important to note that although the donanemab phase 3 clinical trial showed higher ARIA risk, the risk with the updated titration, which I showed you, may be a little bit closer to lecanemab. The absolute numbers are still a little bit elevated compared to lecanemab, but just recognizing that the updated titration may make and provide a more favorable profile when trying to decide between donanemab and lecanemab. Pre-existing microhemorrhages on the brain may actually increase the risk of ARIA. For donanemab, data was presented on this, but it likely applies to both. The more microhemorrhages that you have could suggest that you have an underlying condition called amyloid angiopathy, which is where the amyloid deposits in the blood vessel walls and can make those blood vessels a little bit more leaky, particularly when on one of these medications. That's why the threshold for pre-existing microhemorrhages is set at more than 4. You're typically excluded. But recognizing that in the donanemab trial, even 2 to 4 microhemorrhages showed an increased risk for ARIA. There are some other nuanced differences as well, particularly related to stopping criteria, as well as the concept of neutralizing antibodies, where your body actually makes antibodies to the lecanemab and donanemab. Again, unclear the effect or impact of that, but long-term could certainly impact how well those medications work for the duration. Ultimately, this is a decision between you and your provider as you weigh the risks and benefits and how that fits into with each unique situation. So what's the cost? Well, firstly, the provider must participate in a Medicare-approved registry and place each patient on that registry. It's typically a 20% copay, but this can vary depending on the type of plans, either Advantage plans or supplements, as to what the overall out-of-pocket may be. These are rough numbers concerning cost, but there are certainly other costs as well, particularly related to clinic visits and MRIs, different types of brain scans, and others. And you can see some rough estimates here. One question that often comes up is this lifelong therapy? And a couple things to keep in mind: that people who have more severe side effects or not tolerating the infusion process should stop the infusions, and certainly discuss with your provider. As I mentioned earlier, people who are more impaired don't typically benefit from this approach. So once you reach a certain level of impairment, if it should reach that stage, there should be discussions about stopping the infusions. Interestingly, the lecanemab FDA label was updated in early 2025, and this allows for maintenance dosing every 2 or every 4 weeks after the 18-month time point. The decision to stay at 2 or go to 4 will need to be discussed with your provider and may also be placed in context with obtaining an amyloid brain PET scan to see how much amyloid may have been removed with the initial 18 months. The donanemab FDA label provided a recommendation to consider stopping dosing based on reduction of amyloid plaques to minimal levels in an amyloid brain PET scan. And so discussing with your provider when that should occur within the process will be important. Certainly additional data will become available as we move forward in time and will likely impact how long we treat, the frequency of the treatments, whether or not we need to be concerned about neutralizing antibodies, and potentially the method of treatment, as subcutaneous formulations may be in the works, particularly for maintenance therapy. So in summary, we know that the medications remove amyloid and they do it very well. Patients on these still had some decline, but at a statistically slower rate. And in general, we don't know how these statistically significant findings from the trials will translate into meaningful changes at home for individual patients. Although most patients that had ARIA were asymptomatic, there were some serious side effects, including death. And these side effects require expert monitoring and multiple MRI brain safety scans during the first few months. It is still somewhat costly, even with coverage, but in general has been working pretty well on a Medicare-approved registry and appropriate follow-up every 6 months. And this part is important. While on these medications, follow-up is required every 6 months while on infusions, to check in with your provider, to complete some cognitive testing, and to also complete some questionnaires so that we can track progress and also make sure that we're keeping you safe. Concerning the infusions, they occur every 2 or 4 weeks, depending on the medication. Infusion visits will be scheduled several weeks or months in advance, and it's important to keep several infusions on the schedule at any one time to ensure you have appropriate availability. One of the questions that comes up was, well, what if you're mild and want to wait and see what happens as you move forward? This question is tough to answer for individual patients. Some patients who may be on a very slow rate of decline to start with Waiting may not be such a bad idea. However, we know these medications likely work the best when you start the earliest in the process. And so the recommendation is once you develop symptoms and you get tested and you have that diagnosis clarified, if you're going to consider this approach, the sooner and the earlier you start, likely the better the overall outcome may be as you move forward. Because remember, it's going to take several months for the amyloid to be removed from the brain. And during that time, you will continue to have decline. And as you saw in the data, even people on drug declined as you move through time. But the goal is to put you in a different rate of trajectory as you move forward. And unfortunately, or fortunately, we only have one of each person. And so you can't know if you're going to make that right decision 2 years down the road. And based on the data and all the risk-benefit discussions, you'll have to decide with your provider whether it's the right decision for you. Another question that comes up is, this medication does not make the immune system work less efficiently. And so it's fine to continue with your scheduled vaccinations with your primary physician. And so that's something that often comes up, partially because of advertisements about other types of antibodies that do affect the immune system, because there are multiple ones out there that are used to treat various other illnesses, including rheumatological disease, which affect the immune system. Patients can also continue with their current Alzheimer's disease oral medications like donepezil, or rivastigmine, or memantine if they're already on those. A couple final thoughts. The risk-benefit equation will vary for patients and families. The list of inclusion and exclusion criteria is important. And it's important because it helps to identify people who are at the very early stage of disease, but also helps to identify things that could put an increased risk of harm for individual patients. We recognize we're trying to balance a devastating disease like Alzheimer's disease, and sometimes that may put you in a mindset of trying anything is better than doing nothing. But it is important to weigh that risk of harm, because there is a real risk of harm. Quality of life also needs to remain very central in the decision-making process. And some of this may be due to logistics with the infusion process, especially if one lives a ways away from an infusion center. Thank you for listening to this discussion about amyloid monoclonals and donanemab as well as lecanemab. And please make sure to discuss any questions that you have with your provider, and also review other materials that have been provided along with this webinar. Have a great day.